So I'd like to present my topic here. So the broad category of univentricular heart is the most challenging congenital malformation in terms of its description, classification, and management. So the many terms has been used for decades: single ventricle, common ventricle, or univentricular heart. But these hearts can be described as having univentricular AV connection recently, means the entire AV junction is connected to only one chamber in the ventricular mass. However, as you know, the true solitary ventricle is very rare. Most hearts with univentricular heart have two ventricles actually, one dominant, well-developed ventricle with three components of ventricle: inlet, apical trabecular, and outlet component. And the other hypoplastic ventricle is too small to function independently. So these hearts can be managed by Fontan circulation. So the term functionally single ventricle or functional univentricular heart has been proposed in the concept of the entire ventricular mass is functionally univentricular, in which one chamber within the ventricular mass is incapable of independently of supporting either the pulmonary or systemic circulation for whatever reason. So this heart can be managed by only Fontan circulation. Functional single ventricle can be categorized as the following. The one is univentricular AV connection, including double inlet ventricle and absent AV valve. The other category is biventricular AV connection with hypoplasia of one ventricle. Good example is the pulmonary atresia with intact ventricular septum or hypoplasia left heart syndrome. Traditionally, these hearts was not classified as being univentricular, but nowadays, actually, these patients need to Fontan circulation. That is, the management is similar. It's very useful to use this functionally single ventricle in this category. Another example is unbalanced AVSD or other CHDs with valve or other associated anomalies. Given that the functional single ventricle needs Fontan circulation, in this table shows that the spectrum of functional single ventricle managed by Fontan operation in a heart center in Korea, Sejong General Hospital. Among 200 of patients who had Fontan operation, about 60% of patients had univentricular AV connection and 40% biventricular AV connection. Among the univentricular AV connection, the interesting thing is that isomerism, it was in 1/3, and absent one AV valve 20%, and double inlet ventricle about 8%. And among biventricular AV connection includes CC2GA, some subset of CC2GA, complete AVSD, crisscross heart, PAVS, hypoplasia of heart, and absent anomaly. The other interesting thing is that the double inlet ventricle, the morphology feature of dominant ventricle, the incidence was similar in this data. Let's begin with the double inlet ventricle. We can say double inlet ventricle when the greater part of both AV junction is supported by the same ventricular chamber, independent of atrial AV connection, AV valve or ventricular morphology. The mode of AV connection in double inlet ventricle can be made by the two AV valves or common AV valve. In this case, as long as the both atrium join to the same dominant chamber, so this is the double inlet ventricle. Visceral situs can be any kind. Usually 80% had usual HLHS arrangement and about 13% isomerism. AV connection, as I mentioned, can be two types. And the most important feature is the dominant ventricular morphology. The main ventricle can be left ventricle, right ventricle, or sometimes intermediate. We cannot find any morphologic feature of a right ventricle or left ventricle, although the left ventricle morphology is 80% from the literature. When the dominant ventricle is LV morphology, the small rudimentary chamber, that is small right ventricle, is almost always located in the anterior superior aspect of the ventricular mass and far away from the crux cordis, and almost always gives origin to the aorta. That is, gives origin to the outflow tract, and usually associated with visceral ascites is usually solitus, and VA connection is almost always discordant, very rarely concordant, called Holmes heart. If the dominant dominant ventricle is RV morphology, once again, the small rudimentary right ventricle is almost always posterior inferior aspect of the ventricular mass, usually left, and connected to the crux cordis, but seldom gives origin to great arteries, or usually associated with isomerism and have the double outlet right ventricle or single outlet right ventricle. The rest form is intermediate. I mentioned cannot identify any anatomic feature of LV or right ventricle, and is associated with isomerism. This figure shows the typical anatomic feature of a double inlet ventricle. You know that both atrium join to the morphologic left ventricle, and this main ventricle communicate with the RV through the VSD, and the small RV is anterior superior aspect of the ventricular mass and give rise to aorta. This is the anatomic feature. And once again, the two atrium join to the one LV left ventricle, and the small rudimentary chamber with RV trabeculations give rise to aorta and communicate with the main chamber through the VSD. Another example of univentricular AV connection is absent AV connection, left or right AV connection. The most common example is tricuspid atresia. The atresia of AV valve can be made by just absent AV connection or by ventricular AV connection with the imperforate AV valve. This figure shows the anatomic variant of tricuspid atresia. This is common form of tricuspid atresia. There is no connection between right atrium and the ventricular mass. Instead, the fibrofatty tissue was incorporated between. This is most common type of tricuspid atresia, and actually this figure shows there is two AV connection, but there is imperforated valve tissue, and this is an example of epsilon malformation. This is the specimen feature. You know, this is the flow of the right atrium. This is ventricular mass, small right ventricle. There's no connection between the atrial and ventricle. And this is LV side mitral valve, and left ventricle communicate to the small RV through the VSD. Left side AV, absence of the AV connection is a similar situation. This is the mitral atresia. There's no connection between the left atrium and small left ventricle, and this is the right ventricle and tricuspid valve. Actually, both atrium blood flow join to the one ventricle. This is the univentricular AV connection. Another example is the biventricular AV connection, but imperforated the left AV valve. So, okay, this specimen shows that typical mitral atresia, as you know, the left atrium, small left ventricle, there's no connection, no anatomic connection between this. This is the univentricular AV connection, but the most frequent type is the biventricular AV connection. In this case, the small mitral valve, mitral stenosis and aortic stenosis. This can be nicely classified into the hypoplasia left heart syndrome. And second type of functional univentricular heart is biventricular AV connection with hypoplasia one ventricle. They have a separate AV junctions and its own ventricle, but hypoplasia one ventricle. And this hypoplastic ventricle is too small to support any systemic or pulmonary circulation. The one is the heart disease with severe outflow tract obstruction, critical PS, PAIBS, or critical AS, hypoleft heart syndrome. The another was unbalanced AVSD. So the frequent example is pulmonary atresia intact ventricular septum. In this case, RV hypoplasia is very different and associated with T-valve hypoplasia and coronary malformation. And this figure shows the good example of pulmonary atresia intact ventricular septum, very small right ventricle. So this ventricle cannot support independently pulmonary circulation and can be managed by Fontan circulation. Some patients has this kind of coronary malformation. And left side obstructive lesion, Dr. Kim already mentioned, has this category of biventricular AV connection with hypoplasia one ventricle. And unbalanced AVSD is another case. So one ventricle or AV valve is significantly hypoplastic, thereby unsuitable for biventricular repair. So we can decide to how small is the ventricle is too small. We usually measure by echocardiography the area of the AV valve, and sometimes the length of the small ventricle and the inlet part of anatomy and flow. So we can decide how to manage these patients along these criteria. And other CHDs with valve or other associated anomalies include some subset of Epstein anomaly, discordant AV connection with some associated anomalies, and DORV with remote or restricted VSD. Some patients had a balanced ventricles, but if there is major AV valve straddling or overriding, we cannot manage with biventricular repair. So this is the example of straddling. Straddling means the tension apparatus is inserted to the other side of ventricular septum. In this case, it's impossible to do septation. And overriding means that valve annulus is overrides the interventricular septum. In this case, there is the overriding of AV valve with straddling. These are another example of a functionally univentricular heart. So lastly, I'd like to say Visceral Heterotaxy Isomerism. As I showed the spectrum of functional single ventricle in Sejong General Hospital, the isomerism comprised of about 30%. We have a usually asymmetric organ arrangement, asymmetric right and left, HLHS arrangement, right side liver and left side spleen, sometimes mirror image. But some patient had bilaterally right organ arrangement, usually associated with asplenia, so we call this type right isomerism. Some patient had bilaterally left side organs with bilateral two-lobed lung and long left main bronchus pattern, usually associated with polysplenia. This is a left isomerism. And again, it shows the bilateral right bronchus pattern in right isomerism, bilateral left bronchus pattern, long left bronchus pattern in left isomerism. But the most consistent anatomic feature indicating visceral cytosis is the anatomy of the atrial chamber. And as you know, right atrium has the very well-developed pectinate muscle extend along the tricuspid valve annulus to the coronary sinus os. This is the most consistent feature of right atrial anatomy. And instead, in this case, the pectinate muscle is confined to the appendage, but this part of vestibule is very smooth. There is no pectinate muscle. This is the characteristic anatomic feature of left atrium. In right isomerism, they will have both atrium with this anatomy. In left isomerism, both atrium will have this anatomy. So Dr. Anderson recommended that the isomerism of right atrial appendage or isomerism of left atrial appendage. So right isomerism is usually associated with a very complex intracardiac anomaly, so most needs Fontan circulation. Instead, left isomerism, the intracardiac anatomy is milder, so about 1/3 needs Fontan circulation. So in summary, functional univentricular heart is the heart with needs a single ventricle palliation, can be univentricular AV arrangement and biventricular AV arrangement. The dominant ventricle can be RV or LV, and sometimes intermediate ventricle. And although some patients had associated malformations such as straddling or overriding, some patients has valve anomaly cannot be managed by biventricular repair. So these collectively term functional univentricular heart is heart need Fontan circulation. Thank you very much.